Does manipulative therapy or low-level laser therapy alone or in combination help with facet-related cervical spine pain? Low-level laser therapy is a popular but controversial approach. Although there is some recent evidence indicating some value, its use in the context of chiropractic practice is still unclear. This recent study is a beginning to a search for answers. Published in 2011 in JMPT, this study from South Africa is entitled Chiropractic Manipulative Therapy and Low-Level Laser Therapy in the Management of Cervical Facet Dysfunction, a randomized controlled study. Before we discuss this specific study, let's jog your memory about what laser therapy is, its proposed benefits, and how treatment parameters are determined. There are, of course, many types of lasers. For conservative care, usually lasers that do not focus on a thermal effect are utilized, so-called cold lasers. Even within this category are several types. There are many proposed effects based on what range of wavelength is applied. First is the category of far-red to infrared wavelength longer than 800 nanometers, which tend to penetrate deeper and are more indicated for application to deep acupuncture points, trigger points, and some large muscles. The other major category, visible red wavelengths, which are shorter than 800 nanometers, are more appropriate for superficial tissue application because they do not penetrate as far. Some of the proposed effects and mechanisms for that effect include reduction of pain through inhibition of axonal transmission in small and medium nerve fibers that carry pain. Also proposed is a potential reduction in the peripheral nociceptive afferent input to the dorsal horn, and perhaps reorganization of synaptic connections in the central nervous system that modulate pain. Improvement in oxidative metabolism may speed healing. Reduction of pain and swelling from inflammation may occur through the increase of endogenous opioids, decrease in prostaglandin E2 levels, and inhibition of cyclooxygenase 2, similar to the effects of many pain medications. Dosage is important to determine and can be calculated if the output power and beam are known. The thermal effect of photons is measured as power density. There are two effects on either end of the energy density scale: photobiological stimulation or bioinhibition. In the range of 0.5 to 4 joules per centimeter squared, a photobiological stimulating response is proposed. Dosage at 8 to 12 joules per centimeter squared and higher cause bioinhibition and may be effective for pain management. Dosage is usually modulated through altering the emission or treatment time. Now we'll get back to the treatment protocols used in this study, but first an overview of the study itself. So, how were the patients selected? Patients were recruited to a chiropractic clinic for the University of Johannesburg. The first 60 patients who met inclusion criteria were enlisted. The inclusion criteria focused on facet-related cervical spine pain of 1 to 12 months duration that was unilateral or bilateral in patients between the ages of 18 to 40. An odd inclusion criteria unexplained in this study was that all the patients were female. The exclusion criteria were standard for this type of study in an effort to focus on facet-related neck pain, so patients with prior neck surgery or trauma, neurologic indicators of nerve root involvement, cancer, osteoporosis, infection, rheumatoid disease, heavy analgesic use, or drug abuse were excluded. Patients were then randomized into 3 treatment groups. Group 1 received chiropractic manipulative therapy to the cervical spine. Group 2, low-level laser therapy applied to cervical facet joints. And Group 3, a combination of both CMT and laser. All 3 groups were treated at the same frequency and duration. There were 6 treatment sessions over 3 weeks at a frequency of 2 times per week. The initial consultation was 1.5 hours, and the treatment sessions were standardized at 30 minutes. Outcome measures were taken at baseline and then at each week in weeks 2, 3, and 4. The laser therapy utilized was a Unilaser 201 with an 830 nanometer gallium aluminum arsenide semiconductor diode. Application was at the 3 most painful facet joints applied at 3 points per joint. The power output was 14 to 19 milliwatts, continuous mode with a spot size of 4 millimeters, with a power density of 111 to 151 milliwatts per centimeter squared. Treatment time was 50 seconds at a calculated dose of 5.57 to 7.56 joules per centimeter squared at the skin surface. Determining where to adjust was based on a motion palpation approach to detect resistance combined with pain and tenderness. One examiner was used. This individual was also the treating doctor. The researchers defend this by referring to the literature that states that intra-examiner reliability is better than inter-examiner reliability, an odd defense. The researchers utilized a standard high-velocity short-amplitude adjustment to involve cervical facet joints. There were both primary and secondary outcome measures. The primary outcome measure was a numerical pain rating scale of 0 to 10 and the Neck Disability Index. The secondary outcome measure was range of motion, measured two different ways, using a cervical range of motion instrument and a baseline digital inclinometer. So what were the results? All groups showed improvement for both primary and secondary outcomes. These improvements were statistically significant, but we must examine their clinical significance. First, as a total cohort, meaning all three groups, the Neck Disability Index scores at baseline were in the 40 to 60% category, which is rated as severe disability. At the end of 4 weeks, this had diminished to 20 to 40%, which is the moderate disability range. Looking deeper, though, this was not equal among groups. Clearly, the combined treatment group, having both CMT and laser therapy, improved faster than the solo treatment groups. In the first week, there was a 29% average improvement compared to 14% in the CMT-only group and 11% in the laser-only group. At the end of the 4 weeks, the combined group's baseline Neck Disability Index score was 52 and decreased to 23 at the end of 4 weeks. However, the range was 0 to 52. Well, the good news is that on average, this group was the only group to reach minimal disability. The question, however, is why is there such a high disability score at the end of 3 weeks of treatment and 1 week after the treatment period for the average of all three groups? Not entirely impressive. This is also true of the numerical pain rating scale. All groups started with a baseline average of 6. But at the end of 4 weeks, surprisingly, the CMT and laser-only groups decreased only to an average of 4. That means 1 month after the initiation of treatment, there was still noticeable pain that decreased only slightly. The combined group, though, decreased to an average of 2, which seems more acceptable as an indication of some effectiveness of care. Looking at the secondary measures of cervical range of motion, again there are some disappointments even though statistical significance is reached. Obviously, there's a lot of variation in what is considered normal range of motion for each of the cervical spine movement patterns. However, using baseline measures for the patients in this study, we can at least see how much each increased on average. Remember that both an inclinometer and a cervical range of motion instrument were used. Also, it's important to note that the rotation and lateral flexion measurements were averages of right and left. Knowing that, do you think the improvement on average seen in, for example, lateral flexion, from a baseline of 20 degrees to a 4-week measurement of 26 degrees is clinically significant? Remember, this is an average of right and left, which means on average, there was only 3 degrees of increased lateral flexion to each side. More importantly, this was the best of the 3 groups, the combined CMT and laser treatment groups. The other groups increased only by a few degrees, and that again is an average between sides. So let's take a look at rotation using the cervical range of motion instrument measurements. The baseline measure average was 50 degrees for the combined group and 70 degrees after 4 weeks. This, again, is an average of right and left rotation, meaning that there was an average of 10 degrees of increased rotation per side. That may be clinically significant, but I think minimally noticed from the patient's perspective. What, of course, complicates all of this is that the measurements were taken by the same individual who treated the patients. Certainly, the risk of bias here is very high. Although this study is a good first attempt, certainly the small sample size reduces the power and strength of conclusions. Other obvious limitations are the lack of control group or no treatment group. Natural history over 1 month's time could have been an important comparison. Since all patients were female, no extrapolation to males would be acceptable. The single examiner and treatment doctor combination, at the very least, limits extrapolation to practicality outside of the study, and at worst, could invalidate the range of motion findings. Had there been a separate blinded examiner, the study's risk of bias would have been diminished. Finally, it would have been interesting to follow these patients further out in time, at least 6 months. Let's place this study in context with what the current evidence suggests. 2 large reviews have been conducted over the last 2 years that help frame the current opinion regarding low-level laser for the treatment of spinal pain. The first study, published in the Lancet in 2009, was a review and meta-analysis of randomized placebo or active treatment-controlled trials on the effect of low-level laser therapy in the management of neck pain. The conclusions were that the low-level laser therapy reduces pain immediately after treatment for acute neck pain, and for patients with chronic pain, up to 32 weeks after treatment. But wait, there was a published correspondence concern from a highly respected researcher the following year that pointed out some potentially serious flaws to the analysis and conclusions. 3 of the studies that reported the largest mean differences had limitations or errors. 2 of the studies demonstrated significant difference in the baseline characteristics of the patients studied that would favor the laser-treated group. An actual typo in the other study indicated a significant mean difference that was not reported in the original study. In fact, there was no significant difference reported in the original study. Finally, the danger with many literature review pooling of data for meta-analysis is when the patient populations are dissimilar. In this case, patients had not only nonspecific neck pain, but myofascial pain syndrome and osteoarthritis. The characteristics and responses of these patients may be different among the different groups. A second, more recent Cochrane review evaluated the effect of low-level laser therapy on nonspecific low back pain. Although not focused on neck pain, the results of this analysis does reflect a general consensus regarding treatment using LLLT for neck pain. Their review indicated that there was insufficient evidence to draw firm conclusions, and that although studies indicate that there is statistical significance demonstrated for a positive effect, they question whether these translate into clinically important differences. They state that real laser therapy is better than sham, but neither is better than exercise for pain and disability in the short term. They do state, though, that 2 small studies indicated that the relapse rate for those treated with low-level laser therapy was significantly lower at 6 months compared to control groups. For those practitioners with available low-level laser therapy, perform an in-office trial of combined therapy, CMT and laser, using the protocols outlined in the study to determine a potential benefit compared to your current approach. Use an outcome measure on your current patients before switching to this study's protocol so that you can have a comparison to your current approach. This outcome measure should be a numerical pain scale and neck disability index to keep consistent with the study measures. The range of motion measurements are probably not a necessary component given the potential for examiner error and bias. For those without available low-level laser therapy, wait, watch, and see what future larger and more controlled studies reveal.